Hi, everyone. Welcome. I'm Jen. Sorry, my front door just opened. I was seeing who's coming in my house. I'm Jen James. I'm a sociologist at UCSF. I'm excited to welcome you all to this month's Wisdom Community Forum. Some folks have already started introducing themselves in the chat, so feel free to do that. Let us know who you are, where you're joining us from, what topics or questions or what brought you here today. I'm going to go ahead and share my screen. We'll just do a few slides. I'm not used to this version. All right. So this is the Wisdom Community Forum. We meet every month, usually on the last Monday, but there's a holiday on the last Monday this month. So this is when we're here today. Thanks for joining us at this slightly different time. Our goal, both the wisdom study, but why we're here together, is really to think about how we can move together toward equity and better outcomes in breast cancer for everyone. That's what we are trying to do together, and part of why we want to be in conversation with all of you who have different expertise, work in different communities, work in different areas related to cancer, have your own experience of cancer, and so we can all learn from each other and together. We know that breast cancer isn't just one disease. Sometimes breast cancer is really, really aggressive. Sometimes it's really treatable. We know that who gets cancer when really varies, and it can vary by age, it can vary by population, it can vary by, some people have family history and some people don't. We're trying to learn more about who's getting cancer and what kind of cancer, in the hopes that we can make sure that we are finding them at the right time in a way that's treatable. And we want to better understand why breast cancer has worse outcomes in some communities than others. So today we have a group of folks who are going to share with us and be here to answer some questions. We are starting a sort of mini series, we'll see how this goes, on breast cancer across the lifespan, across the life course, and thinking about understanding breast cancer at a younger age, at an older age. And today we're starting with middle age. What's breast cancer like in sort of middle age, and thinking about some of the questions that come up around diagnosis, around treatment, around risk reduction, and thinking about cancers that occur at middle age. So I really want to introduce our first speaker. Oh, I forgot a slide that was coming. Usually I have my little cheat thing where I can see the slides upcoming, but I don't have that right now. But our format for today's session, we basically, this is meant to be a conversation. We're going to do a little presentation, but mostly we want to hear from you. We want to answer your questions. So if you have questions, you can raise your hand, you can put them in the chat, you can ask them out loud, and we will get through them as much as we can. And we're doing a recording so that other folks who can't attend today can still learn from this. We'll also do a survey at the end just to hear from you about what topics you want to hear about in future events. So breast cancer across the lifespan is the thing we want to talk about. And this is a slide that somebody else pulled, so I don't know the details about this, but just showing who's the probability of developing cancer and the probability of dying from cancer and what that looks like over the years. One thing I just wanted to point out, it looks like these two are really similar, but remember it's a 2.1% chance over the age of 0 to 49, which is a much bigger time period than 50 to 59, when it's a 2.4% chance. Goes up a little bit higher at age 60 to 69, and then 7% at age 70 plus. And we can see that this really mirrors the mortality rates for breast cancer. So it's not exactly equal over the lifespan. And it's something we want to better understand what we should all be doing across all ages to think about breast cancer.
So Jen, I just want to point before you go back.
Please.
Go back
Laura.
to that.
Yeah.
So in some ways, this absolutely tells the story, but in one way, it's a little bit misleading.
Yep.
In the sense that, breast cancer is just much more common as you get older. So it makes sense that you're more likely, your risk of dying of it is higher when you're older. And it's much less common when you're younger. It's a different question to ask.
Yeah, useful to see that through age 70, I think is what this is really saying. Your risk is 3.5%, but through age through the lifespan, it goes up to 7%. So it's double. So half of the risk is after age 70, I think is what these slides are saying. I'm not 100% sure.
It is, but I think it's another question to ask if you happen to have a breast cancer, if you are a person who's diagnosed with a breast cancer, what is the likelihood of having an aggressive or a more lethal cancer, and what types of cancers occur at different ages? So we do know that more aggressive cancers happen when you're younger, but all in all, it's actually a much less common event. So they're apples and oranges.
Yeah.
That, you know, that what we decide and when we try and figure out if you happen to have a cancer, all of this goes out the door because now you have a cancer. And now we're asking, well, what kind of cancer is it? And, you know, what's your likelihood of dying from it? And what's your likelihood of responding to treatments? And how do we prevent that? And I can tell you that in the time that I've been running the I-SPY trial or how we've worked at it, the chance, you know, we have tripled the chance that we probably could save someone's life by getting them the right treatment at the right time. That's one of the reasons why constantly looking, studying, working, improving makes such a difference. Because it is, you know, that there are some cancers that are likely to come back early, these kind of molecularly high-risk cancers, and there's some that can come back and get you much later. Then that's a more common type of cancer. 10 years later, 15 years later, that's a much more common type of cancer.
But and I want to amplify on that a little bit because relevant to risk assessment. I mean, as we get older, the risk of breast cancer, I have 1 or 2 slides, which I may show at some point, but the risk for breast cancer keeps going up, at least until around age 75 or 80. And yet we're recommending, you know, in the Wisdom trial, that older women get screened more often. And that seems counterintuitive, but it's in part because of what Laura just said and what Jen had highlighted in another slide, that younger women tend to get more aggressive cancers. As women get older, the cancers they get are slower growing. And so we still catch them at a curable stage, screening every 2 years and maybe even less in some women in the future. But that's why even though the risk goes up as we get older, we actually can screen less intensively because they're less likely to be fast-growing aggressive cancers. Right. So it's a little counterintuitive when you look at some of the numbers, and it's really amplifying what Laura and Jen had said.
It's saying it's because the screening story is more complicated. You know, we tend to say, oh, screening early detection saves lives, but it's a little more complicated than that. You're at risk for a cancer. What kind of cancer? How serious is it? And what do we want to do about it? That's the hard part. And that's part of what we're trying to explore in the Wisdom study and how we're trying to make sure that we don't treat everybody the same, because that wouldn't be right.
No, all exactly. Right. And I think what you're, I think you're raising that's so important is that there's like so many intersecting and overlapping things we have to think about. It's both sort of like, you know, when and how do I need to screen for cancer? What can I do is there things I can do to change my risk for getting cancer? And if I do get cancer, what type of cancer is it going to be? And what do I do with that? Which really can vary quite widely. I'm seeing a question in the chat, and Ashley, I think you're raising your hand, and we're going to get to that actually in just a minute. There's a question about hormones and hormone positive cancer and not, and I want to get to that. So we'll put a pin in that just for a second, but I did want to make sure, that I'm just going to skip over this one. We go to Diane Hiditsian, who is going to start us off and really start off this conversation thinking about the perspective of a patient and what we need to think about when we think about cancer, specifically sort of across middle age and in the middle age of life. So Diane Hiditsian is a founder and CEO of a 40-year global life sciences digital communications agency serving the biotech, pharma, and molecular diagnostic industry. She lives in the SF Bay area and is a mom of 2 grown kids, a grandmother to 2 little ones, and a 20-year breast cancer patient research and policy advocate. She's an active advocate on the Wisdom study, where she helps with recruitment and retention of participant partners. She's helped design and create the new Wisdom website and works on the newsletter and other communication. And most importantly, with her other Wisdom advocate colleagues, she oversees the study from the patient perspective, making it safe and easy to do and making sure that Wisdom participants have a great all-around experience. So she has been involved in Wisdom from the very start, way pre-Wisdom, and is going to share with us a little bit about her story and her experience with both screening and having breast cancer through these ages. So I'm going to turn to you, Diane, and I will go to your slides.
Okay, and just to follow on the conversation that just happened, so there also one thing about breast cancer is that there's always the exceptions, right? Mm-hmm. And so here I am in midlife when I get my first cancer, but it's not aggressive. but it keeps coming back. So this is kind of another flavor of breast cancer, right? It's not, when it comes back, it's not metastatic, it's not aggressive, but it's something about it likes my body. So here I am in 2002. I call it, you know, kind of my whole midlife of my womanhood, 20 years of it has been kind of defined by breast cancer. So I'm 48. As Jen said, I'm the founder and CEO of my own company. I'm married for 23 years. I have 2 great kids. My life partner is also my business partner. And I decided to, you know, give myself a trip to Italy with some friends. I'm going to take a walking tour of Tuscany, this much deserved break. I'm healthy, and like many other women my age, I depended on my gynecologist for most of my health care because I was healthy. I was perimenopausal, and my gynecologist decided to put me on a low dose form of birth control because I had really strong perimenopausal symptoms, you know, really ran the gamut, you know, the night sweats, the sleep issues, the mood swings, the whole bit. And so I had been having mammograms since the age of 40, and I had actually had a clinical breast exam 6 months earlier. I didn't have dense breasts, one of the risk factors. I had had 2 children. I had breastfed them both for about a year. No cysts or other issues with my breasts as a young woman. So this really came out of the blue. And so I get this, I feel this lump and I go in, and then the technologist finds another lump. And then in surgery, we found a 3rd lump. And I was diagnosed just at my local community hospital 5 minutes from my house. That's where I was treated. This is, you know, 20 years ago. And the first thing I did was ask my surgeon whether I was going to die of this breast cancer. And he said, no, you're not going to die from this. And I asked him whether I could still go to Italy on this long planned trip. And he said, well, we'll see. So within 3 weeks, I had a mastectomy. Again, three lumps, and they were all in the same area, so they would have grown to one big one eventually. The largest was 1.5 centimeters. And then I went to an oncologist who recommended that I get chemotherapy, 4 rounds of it. And there was no Oncotype DX or Mammoprint to tell me whether I had a high risk of recurrence. That wasn't on the market yet. So, so I did get the chemo. So who is running the slides, me or you? Jen?
I am. Sorry. So I just went forward. Was that
so
right?
you can go to the next slide. Thank you.
Perfect. The next one after this? Or is this good?
This was the first one, right?
Are you seeing the breast cancer diagnosis and treatment slide?
This is the second one. The first one had your family. This is now you in Italy.
I think this is you in Tuscany, finally.
Okay.
Yeah.
I'm not, hold on. I'm not seeing this. Okay. So I did get to go on my trip after my first round of chemotherapy. I lost my hair as we hiked to a cooking school. I just put on my trusty hat. And then at night, I would wear my wig that I had, forethought to pack in case I lost my hair. I returned home. It was a great trip, and I'm so glad I went. But I returned home and completed the last 3 cycles of my chemotherapy that summer. And the oncologist put me on an endocrine therapy, which I was on for 5 years. I delayed my breast reconstruction from the mastectomy because I had rushed into the surgery, not knowing that it wasn't an emergency, but I didn't want to rush into the reconstruction. So later that year, I traveled to New York and had a autologous reconstruction, which means that I got a tummy tuck, and then they used the fat from my stomach area and built a live breast from it. And that was great. I was very happy with that choice. So I'm on the, we call it aromatase inhibitor for 5 years. And, you know, every side effect in the book, because I had been thrown into menopause from the chemotherapy. So I since learned that the closer you are to menopause, when you go on one of these anti-hormonal drugs, the worse the side effects tend to be. So, okay, next slide. Fast forward to 10 years later, exactly to the month. And I'm 58 years old now in 2012. My kids are grown pretty much. I'm divorced. I have a thriving business, and I become a breast cancer advocate to try to, give back and kind of help figure out this disease and how we can make the treatments better. And because my surgeon told me I wasn't going to die from the disease, I wanted to try to help the people like Elizabeth Edwards, who I had met, who didn't have the luck of hearing their surgeons and their oncologists tell them that they weren't going to die from the disease. So this second breast cancer really, the first one was a surprise. The second one broadsided me, right? I had no intention of getting a second breast cancer. I had just switched to UCSF to get my mammograms because I was an advocate there, and I had heard that they have some of the best screening numbers in the country in terms of finding the breast cancers that are there, that are meaningful, and also obviously amazing physicians and researchers there. So my first mammogram found an abnormal finding. The tumor was not visible on an ultrasound. I had a stereotactic biopsy, positive for carcinoma. But because the tumor was small, Dr. Esserman, who happened to be my surgeon, recommended a lumpectomy. And since I wanted a breast reduction, it was very easy. Took the tumor out, used some of, took it out of the area that we reduced my breasts from, evened out the two breasts. And it was a very small tumor, 0.4 centimeters, but it was cancer. All of my cancers have been the same pathology, almost exactly, ERPR positive and no lymph node involvement. I was feeling very lucky that this was another new primary in the other breast and not a metastasis. So now MammaPrint was there. That's the test that shows what your risk of recurrence and whether chemotherapy will help you. And so mine was ultra low, which meant that I didn't need chemo. But just to be safe, I joined a trial at UCSF for intraoperative radiation therapy, which means when you're getting the tumor out, and the tumor's out, they shoot a high dose of radiation into the tumor bed. So it's not going through your skin. You know, it can be a little bit more protective of your body. And it's only once, and I was under, so I didn't know anything, right? And this was a trial in that a registry, they're keeping track of the results, and only women with very small tumors could have this type. So I felt very protected. So then we can go on to the next slide. Now this is 2016, and I get, this is 4 years later, I get a recurrence on the left side and right on the scar area. And so again, out of the blue, but you deal with it. So it was again small. So I just had an outpatient lumpectomy. By this point, I'm an expert. I have Dr. Esserman guiding me. I'm not too concerned. I'm again mammo print low, nothing to worry about. So at the moment. So I decided to have that done. But then talking to several oncologists a few months later, I decided to have, I was done with cancer, right? So I decided to have a prophylactic second mastectomy just to not have to deal with this anymore. And so in June of that year, in 2017, actually, I had my second mastectomy. And so that was the left side. And because you can only have that autologous deep flap tummy tuck thing once, we had to figure out where we were going to take the fat from this time. So the reconstructive surgeon said, well, they left your love handles last time. We can use those, right? So it's like, okay, this is a cloud, the silver lining. Next slide, please. So so I have that surgery, the mastectomy. I never found them difficult to get through, and I get back home. And the oncologist calls me and she says, so the lab found a fourth cancer in the specimen, in the mastectomy specimen. It was hiding behind the nipple, a very kind of famous place for breast cancer to hide. And I had had a nipple sparing mastectomy, which, always these advances. So I was concerned about that, right? But they did a very good job of cleaning all the cells out of the area below the nipple. They just keep advancing this stuff. It's just amazing as an advocate to see this. So then I had to go on 5 more years of the aromatase inhibitor, the drug that stops the estrogen from making any cancer in your body that might have escaped. It stops that cancer from growing. And I'm happy to say that next month, June, I'm counting down the days to my last 30 days of this, of 10 years of my life on this type of drug. So that's my breast cancer story, and it brings up a whole slew of questions because this all happened in midlife, and we'll get into that.
Thank you so much, Diane, for sharing. Oh my goodness. That's a big 20 years with a lot going on. And
it makes me tired. I know. It's like, how did I do that?
I know. We're so fortunate to have you here and all the work you've been able to do because of your experience. So we really appreciate it.
Thank you.
Yeah. Lots of questions were raised that we want to turn to. A lot of them centered on hormone stuff, which is what we want to talk about. So I want to get that in a second, but I did just want to note, there was one question about if people always get cancer for a second time, let alone a third or a fourth time. And I wanted one of the clinicians to answer that. My understanding is no, right? It varies person to person.
It's not common.
It's not common. So Diane is exceptional in many ways, one of which is having cancer 4 times. And most people are not that exceptional. But
one of the things that's true,
and
one of the things that's true too, and maybe that little lesion under the areola would never have come to clinical attention. We don't know that. And that's one of the reasons why we're trying to work hard to rethink and redefine what is cancer, right? And, that we know with screening, we find some of these things that likely won't grow and change. And it's a real challenge. It's true in prostate cancer, and it's more common even in prostate cancer. And so, if we had had the tools to be able to say, I can definitively assure you that this is okay, it would have made a big difference, but we just don't quite have them. We're working on it. Mm-hmm. And it's very uncommon. Maybe 10% of people will have a second cancer. Now, if you happen to have an inherited mutation for breast cancer, that risk, if you're a BRCA1 carrier, is more like 50%. So I actually think it's interesting why people who have an inherited predisposition to cancer, like BRCA1, BRCA2, why they don't have more. Maybe you have 2 or 3 in your lifetime. That's less than you had, Diane. But yeah. It is, why don't people who have those inherited mutations have them every year? They right. don't. So your body, does a pretty good job of trying to protect you from developing a cancer. And it's that's remarkable that it can do that. So that's one of the things that we want to understand and know better. Who's good at that, right?
Yep.
And by the way, I did have genetic testing along the way, everyone known to man and woman, and none has been found that I have. So
you're just extraordinary. That's all it comes back to. Yeah. So lots of questions, and I want to start going through some of them and having all of our experts weigh in. So I think let's start with sort of thinking about hormones and what we understand about different forms of hormones across the lifespan and what that means for cancer. So I think there's a few big buckets I wanted to start with. One is birth control, what we understand about what the safety is about birth control and how that relates to breast cancer. Related to that is then pregnancy and breastfeeding, how those relate to breast cancer. And then finally, Diane mentioned going on, I think it was a low dose of birth control, but, going on various hormonal medications around menopause. So Jeff, I don't know if you, Dr. Tyson, want to jump in and what we know about sort of these big buckets of hormones.
Sure, happy to. Sorry, I was actually thinking, I was told we were doing the older end of the spectrum today, so this is sort of a curveball for me. But Diane, what a powerful story, Diane, and you're so resilient through this. I mean, there are many people who would have been crushed by this, and you just enthusiastically keep pushing the science and pushing us, and we so appreciate your spirit through all this. Hormone therapy is the story of hormones and breast cancer is complicated, and we're still trying to figure it out. And Laura, I'm sure, will correct me. But the data on oral contraception has been mixed over time. I think the consensus is that oral contraception raises your risk slightly when you're on it for breast cancer. It cuts the risk of ovarian cancer in half if you're on it for a long time. So BRCA carriers, we actually think it's actually a good thing because of the benefits in preventing ovarian cancer, and the risk for breast cancer is small. And when women go off of it, they actually have a lower risk for a period after that. So it kind of balances out. Long term, there's not a big risk. The story with hormone therapy after the menopause remains controversial. It's pretty clear that there's long-term, there's an increased risk of breast cancer with the combination of estrogen plus progesterone, and that the most definitive data come from the Women's Health Initiative study, and they see that out 15 years of follow-up now, just clearly an increased risk of invasive breast cancer. But interestingly, one arm of that study looked at women who'd had a hysterectomy, and so we didn't need to give the progesterone. So the main reason we give a progesterone along with estrogen and hormone therapy after the menopause is because if you just get estrogen, women have a very high risk of developing endometrial cancer, cancer of the lining of the uterus. And so we have to give the two of them together, or else we really are causing cancer. But in women who had a hysterectomy who aren't at risk for that kind of cancer, the endometrial cancer, when they were on just estrogen alone, they actually had a reduced risk of breast cancer. And that again continued out 10, 15 years. So it's sort of a confusing picture, and it really appears to be the combination of an estrogen plus a progestin that particularly drives breast cancer. And it's probably kind of it's a little bit like the accelerator. I think it increases cell division, speeds up growth. It doesn't necessarily cause DNA damage that leads to the cancer, but it amplifies any cancer that might be present because of other genetic damage. So I don't know, did I cover all the questions you wanted, Jen? I mean, I think, an interesting, the risk for breast cancer with hormone therapy soon after the menopause is relatively low. And that's the period when women have the most, or the perimenopausal period, as Diane said. Perimenopausal and early postmenopausal is usually the time when women experience the most severe hot flashes and sleep disruption and so on. And, most of us feel comfortable using hormone therapy for a short period of time in women who are really suffering and who other alternative approaches aren't working. But we do try and stop that, get to the lowest possible dose and try going off of it periodically, so that once a woman is minimally symptomatic, she comes off of at least the combined hormone therapy.
Yeah, and I would say probably the trade-off, I think that the progesterone is clearly the culprit in this, not estrogen alone. And, if someone's suffering, I would prefer to just give them estrogen alone, a small low dose of estrogen, rather than to add the progesterone. And you can even use if someone's really suffering, you can put in a Mirena IUD and have estrogen. I mean, that sort of counters both. There's a small risk of endometrial cancer, but those tend to be lower risk. So everything's a trade-off. When you think about it. It's interesting that Carol Fabian, who's a medical oncologist and researcher in prevention from the University of Kansas, is running a study that we are just about to open here, which is testing the medication Duave. Well, actually, Duave got taken off the market. So it's the combination of that, which is a SERM, fourth generation SERM, basidoxifene, plus a very low dose of estrogen. And it absolutely takes away people's hot flashes. And she's testing it for risk reduction. It would be very cool if there was something that would reduce the risk of cancer that actually also reduce people's menopausal symptoms. So I think it's a very important study, and it really is something that people have great quality of life. So there's lots that we can continue to learn. There's a lot of really interesting things that I used to think that testosterone was actually a bad actor, but I was just recently in a series of talks last week where dihydrotestosterone clearly shuts off the estrogen receptor, and that for people who expressed androgen receptor in their tumors, that a small amount of testosterone can turn things off. And it might be something that winds up replacing some of the need for ovarian suppression. So the cool thing is that this is the reason to keep pushing, keep working, and keep having clinical studies, because that's actually how we can get to better treatments. And one of the things that I also learned is that medication also, if you combine it with an aromatase inhibitor, prevents you from getting the joint aches that you get from the aromatase inhibitor. So I think there's hope is on the way, and I think that there are cool ways that we can also use drugs at different doses, and we shouldn't be content with where we are and just keep doing the same thing over and over again when there's so many opportunities to make things better.
Well, yeah, and that's sort of what I wanted to just circle back to close out this portion, like the hormone replacement conversation or the menopause conversation, unless other folks have other questions. It sounds like there are options, there are conversations you can have with your doctor. I remember my mom going through menopause at the time when it was sort of like no hormones. Hormones are the worst thing you could ever do, and really just suffering for many, many years, getting very mad at me occasionally when I was a teenager during that time. It sounds like that there are things you can ask, there are symptoms that can be alleviated. These are things you can have with your doctor. It's not just that there's nothing there. Yeah, which I think is important, right?
Yeah, I think that's true always. Medicine is not an absolute or black and white. I mean, I'm sure Jeff would agree with me wholeheartedly on that. Everything's a trade-off. Everything you do has a reaction, but if someone sometimes people have underlying depression, you get a big change in your hormones. It can really trigger a huge, a bout of depression. And that can be very life-threatening. So you can't be an absolutist about things. You have to trade off and understand what are you trying to balance? You're always trying to look for that win-win and how you can put things together. Someone's got a major issue for depression or MS, if they have remitting and relapsing multiple sclerosis or something else where estrogen's important. Of course, you're gonna, like you would give someone estrogen. There's lots of, there's ways that you can try and mitigate risk in other ways. So, it's important that you have a dialogue and that everybody makes choices about weighing the risks and benefits of any action that they take. And so you just have to put it together and start thinking about what matters most and how to try and, do you create a path for yourself that does the best you can, right?
I could jump in one or two things. Dr. Esselman mentioned a SERM, but we didn't really explain what a SERM was. And that's a fancy name for something called a selective estrogen receptor modulator. So we've known that there are good things that estrogen does, like preventing osteoporosis, and there are bad things like causing blood clots and endometrial cancer. And so people have been working on trying to find drugs that stimulate the good components of estrogen therapy and block the bad components. And the drug that Laura was talking about in combination with low dose estrogen is one of those. But tamoxifen is another one. You've heard of that. Raloxifene, which was primarily developed as a preventive and treatment for osteoporosis, is another one which also reduces the risk of breast cancer. So there's a lot of work in this area, and we're just trying to balance out the risks and benefits.
Right. And last thing that for people to know is, instead of taking 20 milligrams of tamoxifen, you can take 5 milligrams. You can take baby tamoxifen, baby tam, and that's much, much better tolerated. It still protects your bones, and it doesn't cause that same kind of endometrial buildup, and it doesn't have the same side effects. So there are lots of options to think about, depending on what your situation is.
And we had some questions about that. So we had a question specifically about efficacy of low dose tamoxifen. And I wanted to sort of ask about this. There's also a question about, as you get older, having hormone receptor positive cancers. So I was hoping that you could both just speak a little bit about sort of these cancers that are taken, these medications that are taken as a form of risk reduction. And I don't know if everyone is familiar with tamoxifen and raloxifene and what the differences between those are. Diane also mentioned aromatase inhibitors. I was hoping you could just, in broad strokes, speak through what are the differences between those, who might take them, and what some of the side effects and benefits are to them.
So the way to think about it is, if you think about the cell, if you're the cell here, that, if you're in a room and you're the nucleus and the door is the receptor, and that's the estrogen receptor, there's a class of drugs that can sit in front of the receptor and block it. And there's a class of drugs that are busy trying to take away the keys. The ones that block it are the SERMs, tamoxifen, raloxifene, basidoxifene, all these different ones that have slightly different properties. And depending on how they are, they can actually bind to the receptor and stimulate it, or they can bind to the receptor and block it. So and it also turns out that it may be that depending on the situation and how much estrogen you have, that these drugs can act differently depending on the context of how much estrogen there is around you. So I think these things are also more complicated. So learning how to modulate the dose, because we tend to bring in one dose and just test one dose. There's one of the most important things is, if you think about it, is one of the keys to the risk reduction that we've been able to achieve in the field of cardiology comes because we've got good intermediate endpoints. So what do I mean by that? If you're at risk for a heart attack or a stroke, we know that we can control blood pressure, we can control cholesterol. Those are intermediate things that we can control that will predict whether or not your risk will go down. That's like blood pressure or cholesterol. If you take a statin, it brings your cholesterol down. You get your blood tested, you measure your cholesterol, it's working. you take something to lower your blood pressure, or you change your diet and exercise and your blood pressure goes down, you know it works. We are missing that in breast cancer. And, this is one of the things that we've introduced in I-SPY. When there is an aggressive cancer or a fast growing cancer, we don't operate first. We give the drugs first so we can see how the tumor changes. That becomes our marker of whether the drugs are working. For estrogen related tumors that are slow growing, we don't have those markers. But one of the things there's two things that are coming up that could do that. One is looking at the breast density. Our colleague Per Hall in Sweden did a study looking to see whether he could change the density. And tamoxifen is known to reduce the breast density. And in fact, he did a dose finding study looking at 1 milligrams, 2.5 milligrams, 5 milligrams, 10 milligrams, and 20 milligrams. And lo and behold, with doses as low as 2.5 milligrams, you could change the density just as much as you could with 20, but the side effects were a lot better. That often tells us we've got a lot of wiggle room. And, that's good to know. So 5 milligrams baby tam is something, actually, there's another study showing in situ breast cancer, it seems to work as well. So that's I'm hopeful that will be helpful. It's a little more complicated and harder to measure in postmenopausal women because their breast tissue is not that dense. But another thing we can do in high risk women is we can look at the background on an MRI, kind of how fuzzy white it is, and whether you've got multiple spots and things. We call that BPE, or background, the background. And when the background goes down, we've actually shown in our active surveillance study for DCIS that it's a pretty good predictor of who's going to do fine without surgery. And so for me, that's the beginning of finding that kind of measure. If you're at high risk, and if you're at high risk, we should screen you with an MRI every year. And we can also use the background enhancement on MRI as the blood pressure or that early endpoint. Now we've got something that helps people say, well, if I take this, I know it's working and I feel like it's worthwhile for me. Those are the kinds of things that Jeff, myself, Allison, all of us are working on trying to bring into the next version of the I-SPY study so that we can be smarter, not just screening, but thinking about who's at risk and how to reduce that risk if it's high, and how to know whether it's working if the risk is high, if we have an intervention, is it working? So that's the kind of story.
That's really helpful. I'm just looking through the questions and making sure we're answering them. And so one thing you touched on there was dense breast. It sounds both that taking some of these medications can help lower or can help reduce the density of your breast, but also getting an MRI is a way to screen better for people with dense breasts. Is that right?
Well, just because you have dense breast tissue doesn't mean that you need an MRI. So what is it, Jeff? About half of women have what we call dense breast tissue, BI-RADS C and D, right?
That's correct. But only about 10% have very dense. And,
right.
Yeah.
So I think if you have very dense breast tissue and you're at high risk, it's not, you're not going to be the issue. You're not going to have better screening with ultrasound or with 3D. What you should do is get a contrast, either contrast mammo or contrast MRI alternating with mammogram. But, we do a lot of just doing a bunch of extra tests, hoping for the best. But, we know that we triple and quadruple the recall rates and the biopsy rates. I just sent Jeff some particularly damning data in that regard. I haven't had a chance to talk to you since I sent it, but it's one of the things that we've been saying, everyone thinks, oh, I have dense breast tissue, I should go out and get an ultrasound as a screen. Don't do that. All you're going to do is triple your chance that you're going to get called back and get a biopsy. And it doesn't help you. Right, Jeff?
More or less. Yes, I would agree. I mean, I never would recommend ultrasound. If we're going to do, if it makes sense, it would be MRI that we recommend, just like we are studying in the Wisdom trial.
And how cool if there happens to be something that'll work as a marker of risk that we can follow to see if it's getting better.
Yeah, that would be fantastic. And Jen, I know one of the questions that came up earlier was the risk for hormone receptor positive therapy. And the answer to the question is yes, as women get older, if they get breast cancer, a much higher proportion of them are hormone receptor positive in the older age groups compared to the younger age groups. And those are the lower risk breast cancers. They tend to have better long-term outcomes.
So that's good news. They're easier to treat. We have better treatments for them. And so so it sounds like what I'm hearing is we know that hormones play a role in breast cancer, and we should think, we need to think cautiously about when we introduce new hormones around menopause. Some of these different forms of therapy that can either block or change the way our body takes in hormones can be helpful in terms of risk reduction, including prior to having cancer or risk reduction for a future cancer. And I was wondering, Diane, if you just want to speak to, you touched on this a little bit, your experience with those medications, if you wanted to speak to sort of how you weighed those decisions or how you might have thought of that prior to being diagnosed, or what you advise people who haven't been diagnosed with breast cancer and are thinking about that.
So I didn't really have an option because I have a genetic predisposition to clotting called factor V Leiden. So I couldn't go on tamoxifen. And actually years later, that's the great thing about being an advocate. You learn things that I don't know if they knew this back then or not, but the aromatase inhibitor may have done nothing for me the first time, because I may not have been, out of, considered postmenopausal. But anyway, they all have similar profiles, although now there's an explosion of new drugs being tested that tend, like Laura was saying and Jeff was saying, that tend to, we're really finding workarounds to these horrible side effects. So, I suffered with the side effect. I am still suffering with the side effects. So I just learned that because I have arthritis that runs in my family, right now, if you're on an aromatase inhibitor, the bone and the joint issues that go on while you're on the drug can make arthritis worse. There have been studies done on this, and I was always told, no, arthritis is not a side effect. So, it is the gift that keeps on giving, right? Like, I consider you want to avoid breast cancer as much as you can, because as chipper as I sound about having gone through it 4 times, I consider myself to be chronologically 10 years older than my real age from what my body has had to go through. Now, I don't know if that's, you guys doctors can tell me if you agree, but that you definitely have collateral damage.
Yeah, and I guess I can talk a little bit about the various side effects of the aromatase inhibitors. Clearly affect pain sensing in the muscles and joints, and we thought it was more that. So arthralgias rather than arthritis. I'll have to review the newer data, and muscle aches often can be limiting, though sometimes if you switch to a different aromatase inhibitor, you may have less of those side effects. It clearly affects bone strength. It accelerates bone loss and the risk for osteoporosis and later bone fractures. So we do worry about that quite a bit. For the tamoxifen and raloxifene, they increase the risk of clots and hot flashes and some other menopausal-like symptoms. They don't have the same, or generally have the same muscle aches and joint aches that you see with the aromatase inhibitors. So again, it needs to be personalized if there's a decision about choosing a preventive therapy or a therapeutic if you have a hormone receptor positive breast cancer. It's quite individualized, and
I would like to see some research being done regarding low risk, if we know what that is, low risk breast cancers, because it is difficult to lose weight on these things, right? Because it's taking away your estrogen.
It's not clear. And I think what's also not clear is a lot of people go on them and go into menopause. And Patty Gantz has done a lot of work suggesting that most of those side effects are menopause related.
Right.
If you have age and you can't exercise, that is also hard. And there is no question about, up to 60% of people are not taking their aromatase inhibitors by year 4. There's been a study, a Seoul study done in Korea, South Korea, that, 9 months on, 3 months off, this is in extended therapy, had the same impact. So do we need these drugs to be continuous? Can you take them 3 months on, 3 months off? We don't know. I think this new, as I said, some of the new work here that the hydrotestosterone actually shuts down the estrogen receptor. It abrogates or just gets rid of the joint aches. And of course, looking into this, some of these drugs are the same drugs that the bodybuilders take. So a little sketchy. Anyway, but I think that I think we have to stop limiting ourselves, saying, oh, we've got these 2 choices and that's it. When you just open the door just a little bit, this affects so many people on a daily basis. It's ridiculous that we can't get our act together to do more studies and more things. I think actually that a lot of, that there can be a lot of pragmatic trials. Wisdom is a pragmatic trial. That means it's stuff that's already out there. You're just trying to figure out how to do it. Having insurance cover both sides of whatever it is you're doing and let it be compared. That was the goal for Wisdom. We didn't quite achieve it, but I'm ever hopeful. But these are things, we think about how much faster we can answer these questions and think about how important it is to have these answers. Jeff's an internist. He's got to manage all these different risks. You take the risk of one thing and bring it down. It may affect the risk of something else. You're bringing down the risk of breast cancer. You're increasing the risk of osteoporosis, which could actually be a bad thing too. So it's everything, we have to keep working. We have to keep testing. We have to stop thinking that there's one dose for everybody, I think that's lots to do.
I'd love to say one other good thing. The trials of tamoxifen in particular, you take it for 5 years, you get benefit out at least 15 years. You continue to have a lower risk of breast cancer for the long term, and the side effects go away once you stop. So that is one of the hopeful things about this. We actually can have long-term benefit with relative. I mean, it's 5 years of potentially challenging quality of life, and that's again, an ongoing discussion between the patient and her clinician.
That's just what I was going to say. I feel like this brings up 2 things that I think are so important. One, I feel like the importance of having a provider who's willing to partner with you and think about what are your values and trade-offs, what is your specific risk to anything, and making these decisions. Because I think there's don't smoke, but other than that, most things are benefits and trade-offs, and sometimes a little bit of this and a lot of that. And it's really, don't smoke and exercise, but anything else, I think there's a lot of controversy, and there's a lot that needs to be really specific to each person. So that's a challenge. And the things I wanted to mention on that, the next 2 things were just one, I think it also centers the importance of really centering patients in research and people's experience, and are they willing to take the drugs, and for how long, and what does that mean, and what do they need is important. And just mentioning that for those who are Wisdom participants, there are tools and there's people in the study who are willing to help people think through some of those decisions, like what their individual risk is and what steps they could be taking to try to lower their risk and what the side effects are. So there's people who have expertise in Wisdom who can help with that if that's something people are thinking through. We have 4 more minutes.
Okay, I was going to say, I noticed in the chat a couple of questions about specific gene mutations, and I was thinking it might be better to have an entire session coming up talking about at least 2 genes were mentioned, CHEK2 and ATM, but I think we could have our genetic counselors on and really have a lot more expertise and address a number of these different issues, because it's complicated. I don't think 4 minutes we have time to really address the subtleties of the risk associated with those mutations.
I was going to say the same thing. We have a lot of really distinct and in-depth topics that are coming through. So we are logging these for future conversations. And I agree. I think ATM and CHEK2 would be a great one to talk about more of these moderate risk genes. I'm just looking through to see what other questions, if there's another one we can get to right now. There's a specific question about I-SPY, Laura. I don't know if you can see in the chat that you want to answer in the chat, perhaps. And then there were just a couple questions that came through about COVID that I thought maybe we've talked about these before, we could do in a couple minutes, is just about swollen lymph nodes and the COVID vaccine. And if that's something folks should be concerned about, or that could happen. And then just also, I think people have a lot of concern about this, is that a mammogram not picking up something in one mammogram and picking it up in the next, and how people should think about mammogram readings given that.
I could jump in about COVID first. And yes, it is a risk. Some women do develop swollen lymph nodes. A patient of mine who had bilateral breast cancer did develop a swollen lymph node. Didn't need to do anything. We'd already known about it. We're able to reassure her and watch it, and got smaller. This is not a cancer. It's not causing a cancer or anything, but it does sometimes the body's immune system in reacting. Part of the immune system is the lymph nodes are part of the immune system. And when it's activated, they can grow.
That's right. It's your factory. You're making lymph nodes.
Exactly.
B cells making antibodies. It's all good. We could actually, if people were interested, I could give a whole webinar on I-SPY. But for people who have fast growing cancers, those cancers are likely to kill you in the first 5 years. About a quarter of breast cancers are those kinds. Triple negative is one of those kinds, but not the only one. HER2 is another one. High risk hormone positive is another one. And the idea is that we used to operate on people, hope for the best, give them what was the standard regimen and without much change. And we just kind of said, well, everyone can't be the same. So it's better to give whatever medicine you think, we started with just giving the standard first. And we found, lo and behold, the people's cancers were very different and people's responses were very different. So there's no point in treating everybody the same. And over the time, we've actually figured out how to change the way we classify tumors. Now we've moved to something called a response predictive classifier. So we know that, that one of the standard treatments now for breast cancer, if you're triple negative, is one of the immuno-oncology agents plus carboplatin plus Taxol, followed by AC and more of this immuno-oncology agent, and then surgery and more of stuff. Not everybody needs that either. About 2/3 of triple negative breast cancers have that immune subtype. A quarter of them, maybe another 10% have this DNA repair deficiency, like a BRCA type tumor. And then the rest of them, the other 25% of them, we don't really know what they respond to, and we have to do better. And the same thing about hormone positive cancers. Some are like, a third of them are basal, and we didn't know that either. And so some of them are what we call luminal B. So we don't have good treatments for them, but this is then, once you know that, then you can start finding out, well, what's the biology and how to change that. So this is a whole effort to say, we're not satisfied with the way we've always done it. We're going to set up a learning system so we can constantly be asking the question, what do we do next? How do we do things? And I will tell you that 80% of the women in the I-SPY trial do not have screen detected cancers. They're all found because they're not, most of them are not found in mammogram. Women find them themselves, or they show up in between screens, either because they're too young to be screened or because they're fast growing cancers. So we can do better there too. That's one of the reasons we're asking the question about screening. What's the best thing to do for people, right? Who needs something more aggressive, who needs something less aggressive? Can we figure out the mutation, being able to find out who's a mutation carrier? We can find that out when you're 30 and get a screening program for you to reduce your risk, and maybe even start studying what we can do to lower your risk. We don't want to keep doing the same thing, and we don't want to be doing the same thing next year that we're doing this year. We can do better. There's lots of options.
And for those who are interested, who aren't familiar with the study that we're gathered here talking about, it's the Wisdom study. It's a way to learn more about who should be screening, when, how often. understanding individual risks for breast cancer, getting an individual risk assessment, and getting some, people have the opportunity to get some advice on risk reduction through that study, especially folks who might learn that they're at high risk. So if you're interested, you can go to the wisdomstudy.org to learn more, or reach out to us via email. If you have questions for you or for others who you think might want to participate, it's open to folks 40 to 74 who are screening via mammograms. And then, our next event is going to be next month, the end of June. We're going to continue our discussion about breast cancer across the lifespan, shifting to other ages. You should get a reminder about it. And then also, I think in the chat, the evaluation link, I'm assuming, will be posted there as well. And we want to hear from you about what else you want to hear about. So thank you all so much for being here. This is so great. We will continue this discussion in the future. So thank you.